I hope this is helpful for you in treating your lymphoma patients. I am going to speak about mostly about dogs because we know quite a lot more about dogs and the different treatments for lymphoma, and there's been a few recent advances in this field. And I'll also speak a little bit about cats, and we can overview the logic behind choosing chemotherapy protocols in cats as well. So the typical presentation that we see in dogs with lymphoma is a multicentric lymphoma, so this is an example of a dog with a peripheral lymphadenopathy. And if we just start at the beginning and talk a little bit about how we diagnose lymphoma, it's relevant because in humans there's been a move towards diagnosing lymphoma by histopathology. And I think this is certainly something over the next 10 years that we'll expect to hear more about in the veterinary oncology field as well. It's certainly at the moment it's completely acceptable to diagnose lymphoma by cytology, and that's the way I do it almost all the time as well. But in human medicine they have identified that there are many different subtypes of lymphoma, and that these subtypes can benefit from different treatments and have different prognoses. So it is logical that there are these subtypes probably exist in canine and feline lymphoma, and there has been some recent literature that's looked into this. And I think as we gather more information about the different subtypes in dogs, we'll be looking at diagnosing more by histopathology in the future as well. When we have a dog with multicentric lymphoma, I consider the minimum database to be hematology and biochemistry and a urinalysis. And I always offer my clients chest x-rays and abdominal ultrasound as well. I don't consider it compulsory, but it's certainly useful information. And primarily it's useful because we're usually treating elderly dogs, and it's good to know if there's any concurrent disease that may affect the animal's ability to tolerate treatment. Also, it can help us to evaluate the extent of the disease, and that means that we can also monitor the response to treatment, and we can also take samples by a fine needle aspirate if we find anything unusual on the abdominal ultrasound, which of course is helpful. We do quite often see changes on the chest x-rays and fairly often on abdominal ultrasound as well in dogs with multicentric lymphoma. On the chest x-rays I usually see a thoracic lymphadenopathy, and sometimes I see pulmonary infiltrates as well, or a pleural effusion. And there is some literature to suggest that when the chest is involved that the prognosis may be worse, but it's quite old literature and it hasn't really been validated recently. Likewise, dogs that have bone marrow involvement most likely have a worse prognosis as well. It is a negative prognostic factor, and those dogs that have bone marrow involvement are classed as stage 5 lymphoma, and there is some recent evidence to suggest there are different ways that we can treat lymphoma if we know that the bone marrow is involved. But there's not a lot of literature, and so we don't consider at this stage that it's essential that the bone marrow is sampled in every dog. There may be a move towards this in the future because certainly they do more bone marrow aspirates in humans than we do in animals. But at this stage, if the client is willing to treat regardless of the stage of the disease, then I don't usually do a bone marrow aspirate unless there's a particular reason that I may be concerned that there's bone marrow involvement, for example, anemia, lymphocytosis, or peripheral lymphocyte atypia, or other cytopenias. But in saying that, there is certainly evidence that even without those abnormalities on the hematology, that the bone marrow can be involved. So it's quite a complicated and controversial issue, and well, really until we have more evidence, we can't consider it that it's a compulsory step in the clinical staging. So if we come back to the dog with the multicentric lymphoma and we look at how the best options for treating, which is primarily what I'll talk about tonight, the chemotherapy protocol choice is affected by the location of the lymphoma, and that's why we stage. So multicentric lymphoma, gastrointestinal, mediastinal, cutaneous, and various extranodal sites can have different treatments, and so knowing where the lymphoma is important. The immunophenotype can also affect the chemotherapy choice, and This is a little bit controversial, and the literature is discordant, and the studies are quite new, but I certainly treat my B and T cell lymphomas differently, and I'll explain to you a little bit further on the reason why. And it's not considered compulsory, but I think it makes sense based on the evidence that we have available to look at the different options for chemotherapy for B and T cell lymphomas as being two different types of protocols to recommend. So when the tumor grade is something else that we look at when we're recommending chemotherapy protocols, and I'll explain all of these a little later, but the low-grade lymphomas we treat differently to intermediate and high-grade lymphomas. So some of the low-grade lymphomas can be treated with only chlorambucil and prednisolone or monitoring. It depends on the disease. But the intermediate and high-grade tumours we certainly don't treat like that. And the difficulty here is that you need histopathology to differentiate the two. And that's not something we very often have in veterinary medicine. And until we have a lot more evidence that's been gathered to say how we should treat these differently, we find it difficult to justify taking biopsies and removing lymph nodes at this stage. And you will all know, just as well as I do, about the client and pet factors that affect chemotherapy protocol choice. And there's certainly finances come into it because these drugs are expensive, and particularly for the large patients. Also travel, whether they're willing or able to come to you frequently enough for intensive chemotherapy protocols, or whether they need something less intensive. Whether it's appropriate for the temperament of the dog to be receiving intravenous treatment or require sedation. And there are a lot of factors that I'm sure you're very familiar with that are quite practical factors that affect the treatment choices. And so it's good to know the different options so that you have something to offer people that may not be able to go for the standard first-line treatments. And speaking of these first-line treatments, my go-to protocol is a CHOP protocol, and these are associated with the longest survival times of 10 to 12 months in dogs with multicentric lymphoma. And these are most appropriate for the most common multicentric lymphoma that we see, which is a diffuse large B-cell lymphoma, which is a high-grade lymphoma. That's what we see most commonly. It's actually a histopathological diagnosis, but the average dog with B-cell lymphoma that's multicentric will have, and most likely has this type. And these dogs respond for about 10 to 12 months with this chemotherapy. And it's given weekly for 4 weeks, and then a week off, and weekly for 4 weeks. And then if they're in remission after 2 cycles, we tend to stretch out to giving it fortnightly for another 2 cycles. If they're not in remission at the time that you would stretch out to every fortnight on the protocol, but if they're in a good partial remission and have a good quality of life, you can continue the same protocol, but usually what I would do is to continue it weekly rather than fortnightly. And the drugs involved are vincristine, cyclophosphamide, doxorubicin, and prednisolone. And you cycle through these drugs in that order. You can see in the first week of the protocol there that L-asparaginase is considered optional, and the reason for that is that there isn't any evidence to suggest that the prognosis is better if you give L-asparaginase at the start of treatment. So I tend to reserve it for patients where there may be a reason why I want to avoid myelosuppressive treatment. For example, those with heavy bone marrow involvement that have a low neutrophil count to start with. They may benefit from starting with asparaginase because it is not myelosuppressive, and so it won't lower that neutrophil count any further, but will kill the lymphoma cells very effectively so that the bone marrow can rejuvenate and develop new neutrophils, increase neutrophil count before you then give the vincristine. As far as other practicalities with this protocol, I do find that most of the referring vets that I speak to aren't using doxorubicin in practice. Some are, and some people ask me about whether it's safe or practical to use it, and it does tend to depend very much on your individual practice health and safety policies and facilities. But it would be my general advice that if you are using doxorubicin, that you can buy it pre-prepared from certain drug companies and to the patient's